You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri, and I'm your host, Dr. Jay Portnoy. It consists of a series of presentations by experts in allergy immunology and can serve as the didactic curriculum for trainees in the field. I hope you enjoy COLA.
Hi, everyone. This is the second hour of Monday, August 29th, COLA. We are very excited to have Dr. Justin Griewe, who is an allergy attending in the Cincinnati, Ohio area. He works with the Bernstein Allergy Group. He received his allergy and immunology training at Cleveland Clinic. He is a clinical assistant professor of medicine in the Division of Allergy and Immunology at the University of Cincinnati. Dr. Griewe is a reviewer for several publications, including Journal of Asthma, Journal of Food Allergy, and Allergy and Asthma Proceedings. He's published many articles on allergies, chronic urticaria, rhinitis, EIB, and telemedicine. Dr. Griewe is the chair of the American Academy of Allergy, Asthma, and Immunology Sports and Exercise and Fitness Committee. He'll be sharing his expertise on food challenges today. Thank you.
Thanks, guys. And from a standpoint of this conversation, I can definitely answer any questions if that works with the format of this, if you guys want to interrupt. But, feel free to interrupt me throughout this talk. And this is kind of more of a conversation because, there's some science to this and there's some art to this. And as you guys go out in your careers, you can learn a lot about this. You can see some challenges in your fellowship training, but until you actually start doing these on a regular basis in the office, that's really where you gain most of your experience and kind of start to kind of clarify, what kind of allergist are you? Are you more aggressive with your kids or your adults? Are you more conservative and don't like to take as many chances? Where are you located? Can sometimes factor into this. Are you super rural or are you with a hospital setting? So there's a lot of things that can kind of color our food challenge kind of experience, and definitely getting out in the real world on your own is going to be the best learning curve for you. So today we're going to go over why challenges are important in the first place, and going from there, really determining which patients referred to you for a diagnosis of food allergy required challenge, and how to perform these challenges in your office with really the confidence and support that you need to really feel like you're doing a good job for your patients, and not just doing this willy-nilly. So we all know that food allergies can impact our patients. Definitely a quality of life issue for both patients and parents. Sibling effect is something we see a lot with. These patients can be very isolated, and every parent has a different spectrum how they treat their kid with food allergies. There's this, of course, the far-sighted one where they're staying home from school for activities that involve any nuts. They're not going to sleepovers. They're not flying on planes. They're not going to sporting events. So that's one spectrum that's a little severe. And of course, there's the other spectrum where parents are very laissez-faire, and these patients are constantly having exposures and accidentally, ingesting foods and getting multiple reactions. So I think a healthy median coming down in the middle and really kind of instilling a sense of a healthy respect for foods that they're allergic to, but not kind of instilling the fear of God in them. And I think, a lot of this is on us as allergists and how we approach that conversation, because I think we've been one of the biggest kind of purveyors of fear and anxiety in this patient population just by the way we address it and the way we talk about it. So I've really been more cognizant of how I bring these risks up, and how I frame it, because a lot of parents will really kind of define their kid by this diagnosis. It's one of the few conditions I take care of where their entire identity is wrapped up around food allergy. I don't see that in asthma. I don't see that in eczema, but for some reason, food allergy kind of has this permeating kind of label to it, where patients are really saying, this is Johnny, the food allergic kid. So I think that's pretty unhealthy for them and for the kids. So anyway, we really want to help kind of address this, not only by the conversations we're having with our patients, but by the services we can offer. And if doing a challenge and getting rid of these labels is helpful, then you guys can do a lot of good in your careers by offering food challenges. So, of course, this is the gold standard currently, and as we'll talk about, it's definitely underutilized in clinical practice. And the decision to conduct a challenge is really kind of in this, sharing of conversation and shared decision making that you guys are all learning about, trying to figure out, what's the best next step for this patient or parent or adult patient. And of course, if there's a really obvious history that this is definitely not a food allergy, this is an intolerance or something else going on, we can even suggest having patients introduce these foods at home. But if there's a concern for an IgE-mediated reaction, but you think, this might not be, an official allergy, then that's where a challenge can really be helpful, is to kind of clarify. And some of your tests will say unequivocally, this is 100% an IgE-mediated food allergy, awesome history, obvious test results that are positive, and that's a slam dunk. But oftentimes medicine isn't that easy, and you're going to have confusing clinical histories and equivocal testing, or so it's not always a black and white and clear cut cases. And definitely, the number one concern for me is a good clinical history. That will help shape or color all my workup and evaluation moving forward. If I don't have that good kind of foundation of a clinical history, then it's really difficult to make good scientific evidence-based decision making moving forward. So really concentrate on that. Now, there's lots of reasons to perform challenges. Of course, obviously ruling out a food allergy is one of them. You can monitor for resolution of allergies over time, assessing tolerance to cross-reactive foods. Peanut allergic patients are classic for this. Mollusks and crustaceans, although it's pretty hard to convince someone to do an oyster challenge if they're allergic to crustaceans. They tend to not be super thrilled about that. Of course, relieving anxiety. You might have a slam dunk patient that's 100% not an IgE-mediated food allergy, but I guarantee if you say go home and introduce peanuts at home, those patients are going to be so anxious and nervous in these specific situations that they just won't do it. So sometimes it's easier for you to just have them come in, even though you are 100% positive they're not allergic, and just do a standard graded challenge just to give them the confidence to go home and actually eat these foods and not worry. So sometimes you can use food challenges for that. And of course, at least in my practice where we do offer OIT, challenges can be a useful way to kind of allow or find candidates that are suitable for this procedure. Now, of course, testing has its advantages, but it also has its pitfalls. The kind of sensitivity and specificity for these tests aren't great. Now, there's lots of new testing modalities that are coming down the pipeline. We've talked about basophil activation testing in the past, but there's some other companies that are getting in the space that are providing, again, their shtick is it's a more accurate, higher positive and negative predictive values. When you use these tests that are a little bit more expensive currently, you're going to have a better outcome with regards to your challenges because it's going to be more accurate. So they're going to give you a better insight into what patients are appropriate for challenges and which aren't. So component testing has been out for a long time, and this was kind of the initial attempt to kind of help clarify IgE testing more concretely and delving into a little bit more detail. And we definitely use component testing in our office, and I'm sure you guys use it in your training. And we look at certain ones that you guys will have to learn for the boards. Our H2, of course, for peanut is a strong predictor of disease. But definitely I would kind of go into the minutia of all this and make sure you're pretty aware of the components for each major food allergen, if not for your own education, but for your boards, because this will definitely come up. But again, these tests are not perfect, and again, we're combining this with good clinical history, and if there's any confusion, that's where the challenge comes in and helps kind of clarify things. But again, hopefully with better skin test or with better testing modalities moving forward, we won't be guessing as much, and we'll have more accurate data to work off of. Now, with the current testing modalities we have, there's definitely factors that can influence the interpretation of these test results, as you can see here. We've got the history, age, ethnicity, comorbid conditions like eczema. All these things can affect the serum IgE levels, whether making them higher or lower than they would be normally. concomitant inhaled allergens, atopic populations, geographic locations. All this can affect the probability of clinical allergy for a given specific IgE level. So it's important to kind of realize that these are available or around. And again, as you do more of these tests and you do see more of these patients, you'll get a better sense of where these things come into play. But it's important to know that this can take place. And of course, there's factors that influence the decision to perform a challenge in the first place. If there's a, again, very classic clinical history or reaction that doesn't really have any odd qualities about it, it's just a classic description, then oftentimes those patients are not good candidates because they'll likely fail. Of course, a recent exposure that caused an issue. I mean, if you have a 25-year-old whose initial reaction was at 6 months and they've never been exposed since, that's different than if they reacted systemically, a month ago. So that's going to kind of color your ability to challenge these patients. Of course, the importance of the food can really play into this. Some cultures and some patients are exposed to certain foods more than others, and avoiding those foods really affect their ability to interact socially or in a religious sense or other areas. So you might be more inclined to try a challenge if that's something that's really important to them. Of course, preferences are something we take into mind, and that colors all these things as well. So just think about these levels. But of course, when we're dealing with patients that have high total IgE levels, like in this case, that definitely is something that's going to affect our interpretations of the results. So I never get lab work for foods unless I get a total IgE as well, because you really can't make an informed decision without that. And this is a good example. This is actually data from an actual patient who came in and all these tests were already taken, but I had to kind of tease through exactly what to do with this patient, even though they really had never been exposed to most of these foods, but had really, really high levels to all of them. And parents were at a loss because they'd been to multiple allergists and said, what do we do? Or, this kid is basically eating nothing, and we don't know what to do. And I think the kid was, around 2 years of age or, 1.5. So we started going down the line and challenging these foods, and the patient passed the vast majority of them, even with levels on paper that would be considered allergic, because of his underlying history of not having a true food allergy reaction, having a really high total IgE. This is a case where you can improve someone's quality of life. But some allergists are hesitant because they see the numbers and they even without the clinical history, they say, well, there's no way I'm challenging someone with a level of 35 to cow's milk. The data suggests that they're definitely going to react, or sesame. I think this patient had a IgE level for sesame at 75, and the patient passed the challenge. So you can't always go by the statistics. You have to, again, take into account the clinical history. But this is where you're going to figure out how you're practicing that as an allergist. Are you going to be more aggressive? Are you going to try this? Or are you going to just, say, I'm uncomfortable doing this, and you're going to have to go somewhere else. So you have to make those decisions for yourself. But again, it's not an easy task. And there's lots of this data out there. This is just one paper back from 2004, I think it was, just looking at the accuracy of peanut-specific IgE testing in relation to a good clinical history and in relation to a really poor clinical history. And as you can see here, as you move up the line with negative testing all the way up to testing over 5, the kind of incidence of pass and fail really kind of correlate to is the clinical history good or is it bad? And when we get it in levels that are really high, like over 5, 77% of patients pass those challenges with an unclear history or a positive test only with no clinical exposure. So again, should give you some confidence that these patients can be challenged and should be challenged, and you shouldn't just go off of testing alone. And of course, if they have a really good clinical history and high tests, again, they're all going to fail. So don't just challenge everybody. I mean, use this data to make appropriate clinical decision making. And of course, there are patients that come in for OIT that have never been challenged, but because their history and their testing is so consistent with an allergy, I'm not going to just challenge them to challenge them. I mean, we're not doing clinical research here, so I'm not going to unnecessarily put people at risk for no reason. But definitely consider these factors when you're working up your patients. And this is now an older study I did a couple years ago with a great group of docs, and this was a survey that we sent out to both the college and the quad. 10% response rate, which is pretty average for these types of surveys. And what we did, we did a survey on how allergists in the U.S. were doing challenges in their day-to-day clinical practice. This was a follow-up from a previous study that was done back in 2012. And we just wanted to update some of the questions and really kind of delved into infant oral food challenges as some of the new recommendations came out with early introduction. So this was an update of what was already out there, but it still provided some interesting insights into, again, how physicians are kind of performing challenges on a day-to-day basis. So of course, the vast majority of allergists thought that oral food challenges were important. And again, almost all of them did open-ended, non-blinded challenges as their method of choice. Compared to 2009, when the survey was released, to 2019, when we did it, the three perceived barriers to performing oral food challenges were lack of time, number one, and that stayed consistent. Lack of staff became an issue, and I'd say, with post-COVID, that might even be number one right now. Staffing issues have been a major issue for a lot of private care doctors and hospital allergy practices, and lack of office space. So, you would think that a lot of this would have to do with safety or, reactions and things like that people were concerned about. But really, if you look at the reasoning behind not doing these things regularly, it's more kind of day-to-day stuff, time, staff, space. So it's more of a factor of what's available in your office at that day and time. So you really have to set aside some staffing and some space for these types of procedures, because if you don't have that space, it's tough to do them. And if you look at kind of the general overall amount of people doing food challenges, 58% performed 1 to 5 oral food challenges per month, and about 82% obtained written informed consent, which actually I was surprised with. I would assume that'd be closer to 100%, but not everyone is getting informed consent. Of course, I would recommend doing that, just not only to protect yourself legally, but also making sure that patients and parents are well versed on the risks and benefits of these types of procedures. So if you have a form in place that goes over that, that's just easy to do for nursing staff. But again, 1 to 5 oral food challenges per month, is not that many. In my clinical practice, I'm doing 1 to 2 a day, and other offices are doing even less than this. So there's a wide range of how many challenges are being done in offices across the country. Now, fellowship training comes into play here. Now, there was a large age range of people that filled out this survey. 56% of respondents performed less than 10 oral food challenges in their entire fellowship. 29% performed no challenges, but that's likely older physicians who didn't have the same requirements that you guys do. I'm not sure how many challenges they currently require, but again, it also depends on what kind of challenges are you guys observing? Are you guys observing high-risk challenges where they have lots of reactions, where you can really kind of get a better sense of how patients respond to foods and what anaphylaxis looks like and when to treat, when not to treat? Or are they all really easy, slam dunk challenges where you're just basically hanging out waiting for them to leave? So if you have those really aggressive challenge experiences, then that's going to prepare you really well. But again, on the flip side, if you're not, you're going to be on your own with not much experience once you get out in the real world. Of course, safety is a top priority for all of us. But in the survey, they also suggested that safety was a top priority, but only 60% reported having a standardized protocol for stopping a challenge and treating reactions. So there wasn't, they were concerned about safety, but didn't really have great safety measures in place and kind of algorithms in place to make sure patients were safe. And only 56% had emergency medicine ready and available to use. Now, that's not to say that it wasn't in the office somewhere, but usually, again, we have our cart out and all our medicines drawn up and ready to go should there be a reaction. So, there's differences in how people practice there as well. Now, again, there's lots of safety data that you can look at food challenges over the years, and some of them have a huge patient population that they look at. Other ones are smaller. But the general gist of most of these studies suggests that food challenges are pretty safe and can be done in a regular allergy office successfully with minimal reactions and infrequent systemic reactions or epinephrine usage. So, again, if you're choosing all super high-risk patients, then of course you're going to have a higher risk ratio. But it just run-of-the-mill challenges with a mix of both low-risk and high-risk patients, rarely, if ever, is epinephrine required. And most of these can be done again in a setting with whether it's rural or urban, wherever you are, you can do these challenges. Because that's one issue I get a lot when I do lectures is, I live in farmland and I'm 60 minutes from a nearby hospital. That's something to consider. But if you want to have a thriving allergist office where you provide everything that big city allergists have, you should be able to do these types of challenges comfortably. Now, if you have a really high risk patient and you feel uncomfortable, there's no reason why you couldn't refer them to somewhere closer to the city. But again, a lot of these things can be done, and you should have the confidence to do them in your office. Late phase or biphasic reactions are pretty rare. They do occur, but and patients are always asking about them because they read about them, but those are very rare occurrences. And again, the vast majority are going to be situations where the initial reaction was very significant or severe. They required epi, and then they're going to react, hours later. I've never had a late phase or biphasic in a mild, grade 1, systemic reaction or something like that. So it's usually the more severe patients that have these types of biphasics. And again, looking at statistics and data, it's easy to be nervous about these challenges, but when you really dig down and say, okay, how many people really had bad outcomes with food challenges in a controlled setting with a graded challenge? There's only been one fatality in the U.S., one I think outside the U.S. as part of an OIT entry challenge. I think that might have been in Japan, but these fatalities are extremely rare, and this is data back to 1976. So we've been doing these challenges for a long time, and so this should, again, give you the confidence to really do this in your office, and again, providing a service for patients that no one else can provide. And as we move forward in medicine, especially because we're a smaller subspecialty, you should be very cognizant of what we can provide that's different than everyone else. I mean, ENT is doing shots and sublingual, derm's doing eczema and hives. There's a lot of crosstalk with some of these subspecialties, but no one's doing drug challenges, no one's doing food challenges, at least not that I'm aware of. So if you're not providing that service, then you're lowering your value as an allergist in whatever region you're going to be in. So think about those things. I know that's not the topic today, but it's an important thing to keep in mind as you go out and practice. And we won't ruminate on this too much, but basically, when we delved into the infant challenge section and got a better sense of, are people doing early introduction challenges? Are they willing to provide food challenges in these younger age groups? And what we found was really there was not a ton of interest in challenging really young patients. A little bit more nervousness, a little bit more concern for safety. I think the fact that infants are not verbal and the vital signs are different just put people off a little bit enough that they're not as confident and willing to provide these types of challenges. Now, of course, there's a lot of us that do these, but it's important to remember that there's definitely a hesitancy in challenging infants in our subspecialty, and I think addressing those types of concerns, whether it be at national meetings or in fellowship training, is important because these patients need these early introduction challenges to kind of live up to some of the things we're learning about early introduction. And again, if we're not offering these things to patients, it's hard for patients to take advantage of the data and limit their chance of developing allergies in the future. Now, again, we talked about targeting fellowship education in this realm. Written consents should be universal, but they're not. All these things popped up as highlights from the survey. So, any questions so far? Anything I missed or that you had questions about? Okay. So preparation. Now, this is a big point because when you're running a busy practice, and especially in private practice, time is of the essence. And if you dilly-dally with preparing doses or going through risk assessments the day of the challenge, you're going to lose a lot of time and your clinic's going to get backed up and you're not going to be efficient. So safety is key, but efficiency is also key in the real world. It might not be as big of a deal in a kind of hospital setting or university setting, but definitely this is important in private practice. So at least in my experience, I spend most of my time preparing at the first visit. So, really making sure patients are kind of aware of what food allergy is, how this is going to affect their kid or themselves if they're coming in for an evaluation, going over their skin or blood testing, talking about all the questions they have about the nuances of a food allergy diagnosis, how to use epinephrine. So all those kind of standard educational keys are going to be really important at the initial visit so that patients not only leave with the confidence to say, hey, I know a lot about my disease process now or my kid's disease process now, I'm more confident going out into the real world, but also when I've got a food challenge coming up in 3 months or 4 weeks, I'm not going to have a million questions at that day either. So get it all out of the way early on. And that can be a combination of both you and, again, ancillary staff, whether it's nursing or whoever you got available to help with that education. And over the years, most of us have kind of developed a gestalt or kind of some talking points that I think our staff become used to and repeat back to patients as well. So this is a really important visit, and make sure you do a lot of that education early on. So of course, we're going to talk to the family or the patient about what to expect when they do a challenge. What is a challenge? Why are we doing it? What are the goals? What are the risks and benefits of this? Review most likely outcomes, review what medications to stop prior to the challenge. We like to get patients off antihistamines if we can. Again, it's not always the case if they're really allergic and have treatments for other conditions. And we're really trying to maximize control of underlying allergic conditions. So I don't want to take them off all their antihistamines if that's going to make their seasonal allergies, go crazy and they're going to come in snotty and congested and sneezing and miserable. So, you want them to come in healthy, and if it involves some treatments that might affect histamine response, that's fine. At no point are these meds going to delay or prevent anaphylaxis if it were to occur. But have those conversations and make sure you talk about all this beforehand. Of course, we talked about informed consent, and again, making sure they're aware of not only what are the risks and benefits, but what's the detailed minutia of that day. What happens on the day of the test, starting from when I arrive to when I leave. How long am I going to be there? Do I need to bring the food that I'm allergic to? How many hours do I need to allocate for this challenge? And if I do have a reaction, what are you going to give me? Do I need to bring my own epinephrine injector with me, or are you going to have that? All these questions come up when talking to patients, and if they don't come up and you don't tell them, they might show up 4 weeks later without the food they're supposed to be challenged to, and with an assumption that they're going to be in and out in a half hour. And so when you throw wait, you're going to be here for like half a day, they're going to get mad and upset. So you really have to prepare them for what's going on. And we'll get into this too, preparing them for what to bring in for their kids if they're challenging to kids, or their infants who is nap time is in the afternoon, and you bring the infant in for a challenge when it's their nap time, it's not going to go well. So there's a lot of tricks of the trade that you're going to learn over the years that are going to make these challenges easier to do. So again, preparing beforehand, educating beforehand is going to save you a lot of time and headache. We have a standard written consent protocol that we give all our patients before we give a challenge. We make sure that we have good vital signs before, a baseline weight, blood pressure, heart rate, physical exam, make sure there's no wheeze or any other thing that's going to show up on a challenge and we're like, wait, did you have that rash beforehand, or is that a new rash? Or did you have that runny nose beforehand, or is that new? Because that's going to be important when you make your assessment during the challenge. And of course, knowing what the appropriate vital signs are for the age that you're challenging to. A 60-year-old is very different than a 6-month-old. So know those blood pressure ranges, know those heart rate changes or those heart rate ranges, so that you're not thrown off or taken aback when you're doing these things. So those are important first steps too. Now, when it comes to safety, this is just another added layer of safety that occurs in our office. We label all of our charts. We color code them depending on the food. We have really detailed documentation. We have timers for each individual patient, so we know when they took the dose and when they're due for their next dose. So taking these little steps seems, a little overboard, seems like it's going to take a lot of extra time. But when you've got 2 or 3 challenges going out at the same time, or you've got 3 OIT patients in one challenge, if you can mix these things up and get confused. So the more kind of detailed data you have, and the more, the less room for error and mistakes, the better. And we found that these color-coded charts and timers and everything else we're doing really helps mitigate these types of accidental mistakes. And then pre-assigned roles, making sure that everyone in the office knows who's doing what and when. What's your nurse's responsibility? What's your responsibility? You're going to be busy seeing patients. You can't stop an entire clinic day because someone's challenging in the other room. So, making sure that everyone knows what their responsibilities are and are comfortable enough to get you when they feel like things aren't going well, because you're not going to be watching that patient the entire challenge. So a lot of trust goes into this, and relationships within your staff, within your work group. So you're gonna. This is like the essence of what a team is. And if you're not good at working with others and you're not good at teamwork, then you're not going to be good at challenges. So I have the confidence and the trust in my nurses to do the right thing, to give the right dose, to get me if things are going poorly, so I can kind of clear my mind when I'm seeing other patients and not constantly worry that the guy next door is going to react and I'm not going to be in there. So have that conversation with your staff and make sure you guys are all on the same page. And if that includes a clear written, criteria of who does what, that's great. Whatever it takes to be clarified. And then, of course, we talk about infants and toddlers and why certain allergists are more concerned about doing these types of challenges. Of course, they're verbally limited. These challenges can take a really long time because they don't want to eat, or again, it's their nap time and they're cranky. And they can get, of course, contact reactions because, of course, kids aren't great at putting food in their mouth well. So there's a lot of things that you can ask patients and parents to do, whether it be feeding the kid with a spoon or a straw, or trying to get the food into the mouth without kind of rubbing it all over their skin and their face. And of course, in this age group, especially, parental anxiety is huge. Not to say that there's not parental anxiety in all age groups, but especially in the infants and toddlers. So dealing with that at the same time you're trying to do a challenge. I had one patient that was literally I came in and they had their EpiPen over the kid's thigh, like ready to go should they show any sign of reaction. I was like, whoa, wait a minute, so there can be some really severe anxiety patients here, and you're going to find out very soon that you're part allergist, part psychiatrist for sure. So get used to those conversations for sure. And we talked about portion sizing, appropriate vehicles. It's huge, not just for toddlers or infants, but toddlers as well. Making sure they bring in chocolate sauce or whipped cream or anything that would be a good vehicle to mask the taste of some of these foods. Because the last thing you want to do is have a food that's ready to be challenged to, and they take one bite and they refuse to eat anything else. So mix it up, have some fun, have some games available. Whatever you can do to get these kids to eat the food is helpful, and have alternatives. Make sure you have maybe 2 types of the same food but in different forms or in different vehicles, just so you can try things out if the first attempt fails. So and sometimes you'll do this and they won't even finish the challenge, and they'll fail miserably in the sense of they didn't react, but they just didn't eat enough to be considered a true challenge. And in those situations, you say, sorry, we tried our best, and you bring them back another time. Maybe not during nap time or during another time of day, but you sometimes have to keep on trying with these patients. Yeah, and ample time to feed is huge. These patients should not be scheduled for 3:30 in the afternoon. They should be morning challenge patients, which fits in perfectly with not only not being their nap time, but giving them a sufficient amount of time to do the challenges appropriately. And the good news with infant challenges is the vast majority of these patients, have skin-related reactions. Anaphylaxis, of course, is rare, but the vast majority will have urticarial or angioedema episodes, especially in those infant challenges that we talked about. Skin prick testing was not accurate test to predict the type of reaction. Higher specific IgE levels was associated with more severity, but again, that's not 100% across the board. And we talked about, bringing tons of stuff to help ease the kid into the challenge, make the area that they're sitting in feel more like home, whether it's having a stuffed animal or a family member or familiar cups or plates or utensils they use at home, favorite toys or I mean, I'm all for tablets and movies, whatever they can do to distract themselves. We used to say bring moral support like grandma or grandpa, but with COVID, we've had to lessen the amount of kids and family members that come in for these challenges. And then again, procedural forms, documentation. It gives you a good sense of what happened during the challenge. At what point did they react, if they did, what was given, etc. So just make sure you have standard forms that are easy to go back to and look at. And then especially if you're coming back years later, okay, say, hey, they failed when they were 2, they're 7 now. What happened at that last challenge, and where should I expect or be concerned? So those are nice things to have. And the goal amount of food is interesting. Definitely an age-appropriate serving is important, but there's no like set gold standard thing where it's like you have to feed this amount of grams of egg or this amount of grams of peanut butter in order for it to be considered a true food challenge. But definitely a serving size, what we would think of a serving size, is important. But as you'll find out, the accuracy of these things are not paramount. It's about doing the actual challenge and seeing where things go. Definitely mimic what a real world exposure would be, and go from there. And this is where most people get kind of stuck or confused. Like, how do I do food challenges? And, how do I know what to do with the first dose and how much for the second dose? And it's not as complicated as you think. Now, there are standard protocols and things you can look at on publications, but really what I do and what a lot of my colleagues do is start with a full dose, your standard serving size that you're going to get to, divide it in half. Then again, divide it again, and depending on the severity or risk for the challenge, you can do anywhere from 3 to 4 doses. 5's pushing it. I don't go anywhere past 5 because I think, again, if you're doing a 10 dose graded challenge, you're getting into the realm of potential desensitization. So if they can pass with 4 steps, that's ideal. And this is, again, just an easy way to conceptualize it, thinking of a pizza pie and just continually dividing those doses into smaller and smaller amounts, and then go from there. So you don't need to know the exact amount of milligrams of protein in each bite. It's more of a guesstimate work here, looking at percentages of food ingested. So don't spend too much time on this, and don't kill yourself trying to get the exact measurements. And we found that even with OIT, again, OIT, we need to be much more succinct and accurate with regards to what these patients are getting. But even in those situations, we're finding that there's pretty drastic differences in their tolerability, even at really low levels, where slight shifts here and there of a few milligrams, even in a severely allergic patient, is not that big of a deal. So we at least I've seen that in my clinical practice. We don't have to be as accurate for these food challenges. So I think we're getting close. Well, we got another 5 minutes or so. So, baked milk and egg is tough. Definitely baked milk and egg challenges are the most concerning from a reactivity standpoint. I'd say the 3 foods that I've had the worst reactions with are milk, egg, and wheat. And baked products can cause delayed reactions. So you have your kind of standard protocol where you're in the office for a certain amount of time, and it's not unusual for me to hear that, half an hour or 45 minutes after leaving the office, that some of these patients have a reaction. So factor that into the time that you observe these patients, especially if you're concerned and you're this is a higher risk patient, because they might have a more delayed response. And most of again, I don't know if anyone in the room that's not a fellow would agree, these are usually the more severe patients, and again, the weak patients for sure. And for those low risk patients that are doing well and have a mild, let's say they do have a mild reaction, I have sometimes transitioned them over to baked products on a regular basis, kind of in a pseudo OIT approach. Again, it's hard to really determine exactly how many milligrams of protein are in each bite of a baked muffin. That's why some of these baked muffin challenges can go awry so quickly. And we definitely don't offer baked OIT because, again, we can't control the amount of protein in the bites that they're taking. So this is still a muddy water area, but definitely just be leery of these patients and make sure that you're watching them closely. I divide my patients into higher risk and lower risk patients. And so when a nurse comes in, they say, are you doing a high risk or a low risk challenge? And that'll give them a sense of where I'm at for this patient. And again, that depends on the clinical history, the blood evaluation, the skin prick testing that we've done in the past. And for those high-risk patients, I definitely consider, adding another dose, whether it's 4 or 5 doses. But I definitely start with maybe a little bit smaller amount to start, and again, do a more gradual increase in the amount for these more high-risk challenges that I feel are appropriate. And we talked about this kind of in detail already, so I won't go this into much detail. And timing is interesting too. I mean, everyone has different protocols, and some people wait 15 minutes in between doses. Some people wait 20, 15. Again, there's no set fast rule, but definitely give yourself enough time where you can allow the patient to eat the food and then progress if there's going to be any reaction, because you don't want to continue to stack doses over time and end up with a more severe reaction. So give them that time to ingest the food and then observe without going too quickly. Now, again, with a lower risk patient, you're not as concerned about that, but a high risk patient for sure. And we talk about big products being an issue. And then observation times afterward is another question mark. How long do you keep these patients? If they have a reaction and you need epinephrine, how long do you need to observe them for? And again, there's no set rule for that, but as you practice, you'll kind of get a sense of what works well for you and what works well for your patients. So that comes with clinical practice. And again, some of these challenges fail. Some will fail very early on because patients refuse to eat the food, or infants refuse to eat the food, or they'll fail, in the middle of the course where they just get full or decide that they just are done eating. And the question is, is this a past challenge? Is it not? How much was ingested? What are the risks at trying additional doses at home? How are the parents with relation to anxiety? So this is going to be a conversation you have with both yourself and the parents, and kind of figure out, okay, what's going to be best for this patient? Are these parents trustworthy enough or anxiety prone enough, not prone enough to do this at home? Should we have them come back? So, this is the gray area of medicine that's not taught in fellowship, that you'll have to kind of wade through the waters yourself. And of course, nonverbal responses. Again, this is all experience as well. You're going to notice some signs and symptoms with some of your patients in food challenges that maybe at the beginning of your career might seem mild or moderate or nothing to worry about. And then as you get more experience, you'll notice, oh man, like I need to be watching this patient. Flushing of the ears seems very benign, but a lot of times patients will be like, man, his ears look a little red, or he starts kind of sniffing and mom doesn't pay attention because he got seasonal allergies, but you're just noticing that sniff a little bit more, and then he's running and dripping more, and then all of a sudden he's blowing his nose, and then you see this kind of progression where it's going to get worse. So don't ignore those kind of mild signs and symptoms, but for nonverbal patients, you really have to pay attention even more, and trust parents. I mean, parents will tell you when things aren't going right or their baby or infant looks odd or different. You might not notice it because you don't spend time with them, but if they're, and again, a lot of these patients are anxious, so you have to factor that in too. But usually if a parent is insistent that this is not right, I take their word for it, because parents usually have a good idea of what their patients or what their kids are feeling. Having well-defined, clear stopping criteria, especially if you're not actively running the challenge all the time and in there all the time, so that your nurses and ancillary staff are well aware of what your expectations are. There's lots of examples of these. Again, we talked about vital signs and knowing the appropriate age ranges. And then failed challenges, and I'll stop here after this. We always kind of view a failed challenge as like this kind of lost opportunity to provide patients with a clear kind of cure or fix for their food allergy. But oftentimes you can use this as a teaching point, because I think it's rare that you get a patient in the office where they're actively responding to a food, they're having active symptoms, and you're treating them with epinephrine, for example, and you can really use that as a teaching point. So, of course, the number one goal is to make sure the patient's safe and recovering, but talk about, the epinephrine while you're doing it, show them where you're putting it in, how you're injecting it, after they get it done, how did it feel? Was it scary? Was it not? A lot of patients are like, wow, that really wasn't as bad as I thought it was going to be. And that's going to give them confidence if they ever need to use the epinephrine injector at home, that, oh, hey, we already had this in the office with Dr. Griewe, and, it really wasn't that bad. It wasn't that scary, because a ton of our kids will not inject epinephrine, and same with the parents, because they're scared of that needle or they're scared of injecting their kid. So if you can talk about, the process while they're getting it in the office during a failed challenge, that's going to be a great teaching opportunity. So don't miss out on that. And again, another opportunity to kind of instill confidence and not fear. Empower your patient, and don't make them feel kind of in despair or scared. So those are all important concepts as well. And of course, with the past challenge, making sure that they're incorporating this food into the diet moving forward. Some parents will challenge to a food and never, give it to them again. There is some data suggest that could lead to a recurrence of the allergy. So, make sure you're imparting on them the importance of keeping that food in the diet. It's not like OIT when they need to do it every day, but again, on a fairly regular basis. And there's some good data on that in the literature. So I think this is going to be something that's going to continue to be in demand in our practice. As I mentioned, we're the only subspecialists that offer challenges, whether it's food or drug. And if we're not doing these in our clinical practice, you're not kind of maximizing your value in the community you practice. So demonstrate that value by providing these challenges, and the need for them are only going to go up as we move forward. Increased rates of food allergy, increased rates of poor diagnosis of food allergy. So a lot of people walking around out there that don't have a true food allergy that need our help, and these challenges can help clarify those things. More and more therapeutics for food allergy. OIT is just kind of us dipping our toe in the water. I think in the next few years we'll see other treatments coming down the pipeline. So all these things will likely require food challenges. But if you're uncomfortable providing a food challenge in your office, there's no way you should be providing any sort of food treatment like OIT or anything coming down the pipeline. You should be well versed and confident in doing this, because if you're not, then these other treatments are a little bit too advanced and require that oral food challenge kind of foundation to move forward. So keep that in mind as you guys move forward as well. So we won't keep it too long. Any final questions or anecdotal experience in your own fellowship that comes to mind with regards to food challenges?
Thanks, Dr. Griewe, for a great presentation. I actually have a ton of questions for you. So we get to do, thankfully, a lot of challenges at Children's, which has been really helpful. And like you were saying, sometimes the subjective stuff, it's kind of hard to pick out, what maybe the sort of prodromal, especially abdominal pain I've noticed is either something or it's just maybe anxiety. I was kind of wondering how in your clinic is that managed? Because when we're doing challenges, we're just doing challenges. We're not seeing any other office patients. So I was wondering, as an attending, how do you manage that from a time perspective?
Well, definitely with a trash can. Now my nurses are great, and we just recently designed our own office and had the chance to kind of cater it to our food challenge patients, our OIT patients, our SHOP patients. So we went for a more open concept with a kind of 180 view of all these challenge rooms, so that nurses have kind of eyes on all the time.
Awesome.
So that's been really helpful because they're kind of willing and ready to act if any symptoms occur. As we mentioned, that conversation with nursing and that trust in your ancillary staff to get you when they think things aren't going well. So my nurses are completely comfortable knocking on the door, interrupting a patient visit, and getting me out of the room, and we'll address that. And again, when you're running a busy practice, patients are fine with that too. I mean, most of these patients that you're seeing are food allergy patients or allergic patients to begin with, so they're more than happy to wait and make sure that you're treating the kid reacting in the other room. So I've never gotten pushback from these interrupted visits. But no, with experience and with nursing that's been here for years, they're really good at noticing these symptoms too. And I would say they probably are a little bit more conservative and get me earlier on, which is fine. I'd rather have them interrupt me for something that's benign and not treatable versus waiting until things get too severe. So it's this nice interplay between running a practice and having nursing staff that's really good at recognizing these reactions. But definitely, these milder symptoms or the onset of some GI upset, it's really hard teasing out anxiety versus true objective symptoms, and I've been wrong in some situations and I've been right in others, but I would say that those GI symptoms are usually the precursor to additional symptoms, and I always have I've had too many vomits on the floor over the years to not take those complaints seriously. So as soon as anyone suggests that, I make sure I have a trash can right next to them just in case. And we're watching them a little bit more closely, but yeah, definitely that nausea a stomach upset can be one of the first kind of signs and symptoms that the reaction's progressing. And I usually don't updose when they're having those symptoms. I kind of say, okay, let's hold on. We're going to space that 20-minute window out to, let's say, 35. Let's see if those symptoms improve. Sometimes if they're mild and they're not progressing, I might repeat the dose as opposed to increasing it, just to kind of tease out, is this something I need to worry about or is it not? So again, art and science combining to make these clinical decisions, and and I don't always get it right. There's sometimes where I could have sworn that this was just anxiety and nerves, and it ended up not being. So you're going to get it wrong, but the fact that you're trying and doing it is really all you can ask for.
Awesome, thank you. And then, sorry, one more question. What are your thoughts on like back-to-back challenges? Not necessarily the same day, but maybe next day. And what's your personal take on at-home introductions? And then I'll stop.
Yeah, I mean, I don't have any problem with challenges that occur sequentially, as long as again, we're not dealing with maybe some of these challenges in really high-risk patients. I mentioned baked egg and milk. If it's something that really has caused some major symptoms and reactions, I would say spacing those challenges out a little bit further would be helpful. But for the vast majority of our challenges, they can come back the following day with no problem. Now, the question arises, do you give patients time to introduce these foods multiple times beyond just the challenge in the office? Are there rare situations where patients pass challenges but then react at home? Yes. Is that significant or severe enough or frequent enough that I bring all my patients back the next day and challenge to that same food? No. But it's definitely something to keep in mind and think about when patients go home, and a conversation to have with your parents and patients. Again, we mentioned introducing these things regularly at home is important. So that could muddy the waters a little bit, but I don't think it occurs frequently enough to drastically change. And we have some patients driving from West Virginia or Kentucky or far away where it would be really a lot of time and effort for them to come back multiple times. I mean, they sometimes come for a week and they'll do multiple challenges that week just so they don't have to drive back and forth. So yeah, we do that all the time. And then what was the end of that question? I think there was one more aspect.
Yeah, and just your personal take on like what your threshold is for at home.
At home.
Yeah.
Again, it depends on the anxiety of the patient and the parent. There's so many times where I've told people to go home and challenge to these foods and they never do. So making sure you're addressing that. I mean, any patient where I think that there's a risk for a reaction, I always do in the office. But again, if it's this history where there's really very little concern, then I'm happy to encourage patients to do this at home. But if there's any semblance of this might be true IgE and there could be a reaction, I don't risk that. I have them come into the office.
Awesome. Thank you very much.
Hello, I'm one of the allergists here at Children's Mercy, and I have more of a process question rather than a question on the food or oral challenges. I was wondering about what kind of ratio, nursing to doctor to challenge ratio that you use, and how does it work with your flow between, I know you said, it works out pretty well, but numbers of like clinic patients versus challenges in half day or a day?
Yeah, I mean, I would say we have, usually 2 doctors working in our office at the same time with anywhere from, again, depending on the day. And as we mentioned, a lot of issues with staffing in general has plagued a lot of us. But in general, we have around 3 to 5 nurses on any given day. So that's a pretty decent ratio for rooming patients, performing, pulmonary function testing or other skin tests that we need in addition to doing the foods. And again, as long as we talk about preparation, as long as you're preparing beforehand, you're doing the educational component before they come in, they're well aware of all the parameters that go along. So you're not sitting there for an hour educating them the day of. You've got, a standard food challenge protocol already set out and ready to go. I'm not physically preparing those food all the time. My nurses sometimes do. I say, oh, this is a less conservative challenge. Let's do a low risk challenge, and they know exactly what that means and how to prepare it. So I'm not sitting there doing all this. I'm in patients' rooms doing all the day to day, and then if there's any issues, I come out. So it can be done, but it takes a lot of preparation. Again, trust.
Sure.
and kind of knowing how your office flows. But yeah, are my nurses sometimes overwhelmed and have lots of things going on at the same time? Yes. But more often than not, it can be done in a safe and efficient manner. And because the way our office is set up, we feel confident that someone's got eyes on, at all times. So it's, and most of these kids aren't challenging by themselves. They've got a diligent parent that's sitting right next to them and is going to warn you if they feel like anything's going on. So there's a lot of safety measures in place to prevent kids from being ignored or not treated appropriately. But it's definitely a learning curve, and it wasn't as smooth as it is now, when we first started this. So I think with time and experience, you can add more and more patients to the schedule.
Sure, thank you.
Well, you guys, I should have my email. If you don't, feel free to shoot me an email if there's any additional questions that come up. I'm happy to answer them. But yeah, good luck with training and careers and all that stuff. This is a fun topic, and hopefully will be an area of your practice that you really enjoy and get a lot of patient feedback from. I think they really view this as a valuable part of their workup and evaluation.
Thank you so much. We appreciate it.
All right, guys. We'll see you.